أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear friends, colleagues and students who are willing to or wishing to or ambitious to learn how to report the X-ray chest plane. Now I have already described about 4 cases previously. So this is the 5th case which I am going to discuss and report it. So this is the case in front of you, and this is the 5th case which I want to do. I am Professor Ali Haider. I am the visiting professor of medicine at Jinnah Sindh Medical University. So case number 5 is a 65-year-old smoker. Reporting X-ray chest 5, a 65-year-old smoker was attacked by fever with rigors, right upper chest pain, cough productive in nature for the last 6 days. It is acute in onset. He brought in casualty when he noted the streaks of clotted blood in the sputum. It is definitely hemoptysis. On examination, temperature was 102 degrees Fahrenheit, pulse was 110 per minute, blood pressure is 150 by 100, it is higher side, tachycardia, there is definitely temperature increase in this condition. So, in addition to it, the upper right chest wall was not moving in inspiration and tender at the same area, and respiratory, because it is respiratory 24 per minute. There were dull notes on auscultation with increased tactile vocal phromatus, and there were dull notes on percussion with the increased TVF plus bronchial breath sounds. What are bronchial breath sounds? Inspiration is equivalent to expiration, and there is a gap between the two inspiration phase and the expiratory phase. Definitely there will be a gap. It is associated with the coarse craps plus bronchophony. What is bronchophony? It means increase in the vocal. It is the vocal resonance which is increased on that side. Were noticed at the same area. Now investigations were hemoglobin was 17 gram per cent. The total leukocyte was 19,000. It is neutrophil 80%, so it is neutrophil leukocytosis. The predominant acute inflammation. Lymphocyte was 16%, slightly lymphopenic, and ESR was 60 millimeter per first hour. It is acute phase reactant. Random blood sugar was 155. Urine RE was protein positive +1. You can neglect it. The X-ray chest was taken and presented in front of you for the reporting purposes. Now this is the scenario. In this case, the acute condition is there related with the chest, with the respiratory tract, most probably. Now this is extract the soft data and the hard data from this case, and it is a common one which you will see in your OPDs. So this was the chest which was done. X-ray chest PA view was done. Try to do the PA view. Now reporting, first of all, I will write always requirements. Although it is the patient is slightly tilted in this X-ray. Yes, tilting is there, you can see. But actually he was straight, tried to become straight because of the pain probably. He was not able to state properly. The spinous process is first S plus S plus S. It is a PA view because dominantly the middle mediastinum is marked. It is hazy rather than the vertebral spine, which is not seen here at all. So requirements are there. The S plus S plus S first is the straight. This is the spinous processes. Is going like this on the left side because of the pain. It is not lordosis. So patient was in a state. Now mark another line here as a sternoclavicular joint at this joint, imaginary line, and one line was a spinous process. Both sides should be 90 degrees. So the neck is not rotated. Deeply inspired and hold the breath properly. Here I can't count the ribs properly because of this opacity. First rib, second rib, third rib, fourth rib, fifth rib, sixth rib, seventh rib. It is seventh rib actually. For the dome, if you write down, draw a line here. So he was in standing position. So S plus S. And third S was that he is deeply inspired and hold the breath properly. Eighth rib. Ninth rib is also seen. He is deeply inspired and he was not expiring and hold the breath properly. It's a very important point. So bronchovascular markings are visible in this X-ray. They are not haziness. You can see clearly. You can see and appreciate the bronchovascular marking clearly. The other point is the trachea, which is here. One aerogram is there, one is not there. It is in the line. It means that trachea was central. The bony skeleton, whatever seen is this, the intercostal spaces. The first, the upper border, lower border, upper border, lower border. At the mid-clavicular line, the intercostal space is about 2 or 2.5. So this is neither dilated nor it is narrow space. Here there is definitely spaces are not seen. The scapula, the medial border should be marked. Here it is buried in this opacity. Here it is in here. So it's all right. It means there is nothing. The spinous processes or the vertebral column is this, and there is no cervical rib which is seen here. No accessory rib. Soft tissue shadow around it, here, 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 and here, and here. Nothing significant. Take your central, I always said it, and then we will report and compare the lung fields are divided here at the second rib, straight line, at the fourth rib, straight line, cutting there. So upper, lower, and middle, right lung, upper, middle, and lower left lung field. There are 6 lung fields. Describe it now. Now, apex here is clear, it is not clear. Apex on this side, afterwards is the first intercostal space. Here it is completely blocked by the opacity. Completely blocked by the opacity. Second, the third one is also blocked, and the fourth one is also blocked. Means that it is the upper lobe which is involved by the opacity of this shadow. If this is opacity, you are describing a single opacity which is seen, it is called pulmonary nodule. So is after the recognition that it is the opacity, it is single opacity, yes. The second question is homogeneous and non-homogeneous predominantly. Homogeneous because very few aerograms are seen, very, very few. And it is without a definite curve, means that definite curve was not seen here. Only the border here it is seen, the fissure at the level of the fissure about. And this is the demarcating line of this opacity. So homogeneous opacity without a fluid level or LHS curve. Now this was the description. Describe whole opacity. Lower down, comparing with the other side, nothing. Only there are bronchovascular markings are seen in normal proportion. And then we got here describe this one, the upper dome of the diaphragm. Here it is curved diagram. The costophrenic angle and cardiophrenic angles are clear. Here on the left side, costophrenic angle and cardiophrenic angles are clear. The lower part of the middle mediastinum is visible only. Upper part is not visible. So the size is concerned, of the heart is concerned, lower part. It is normal limits. This is the border, although it is not a smooth border, it is a straight one. Describe this border, left border, and describe this border, this one, although it is blocked here. And the upper part of the middle mediastinum is definitely not seen. You cannot comment except this one, aortic knuckle. So this is called cellular sign. Silhouette sign or cellular sign means you have blocked some part of the middle mediastinum. So isodense with it. This is called silhouette sign. Either the pulmonary parenchyma is involved or the pleura is involved, which is masking this border. Definitely pleura or pulmonary parenchyma. Silhouette sign or silhouette sign is present in this patient. Hyla is concerned. This is the right hyla, which is visible, C-shaped, it's the normal size and shape. The right hyla is not visible, it is masked because of silhouette sign. And the lower part is seen only with the bronchovascular markings of this hyla. So, conclusion is that we have dealt with the opacity, which is homogeneous opacity without curve. It's a single opacity. It is neither displacing anything. Trachea is not displaced, it is not displacing the mediastinum either. And it is without curve, no LSS curve, no meniscus sign. So differential diagnosis definitely is wide available. Otherwise, all other parameters are normal. Differential diagnosis already said the acute inflammation or the result of acute inflammation, the chronic inflammation or the result of the chronic inflammation, the tumor and the tumor-like state and its complication, and the miscellaneous conditions like allergic condition, pneumoconiosis, parasitic infestation, and autoimmune diseases. All can cause this obesity, remember. All can cause a single obesity, homogeneous obesity. But according to the features, clinical features, data was actually given to you. It is acute inflammation of the lung involving the parenchyma very extensively. It is consolidation, and there are 4 stages of consolidation. This is the stage of the red hepatization because no aerograms are visible, no air bronchogram pattern is seen. So it is the stage number 2 of consolidation, of lobar consolidation. It is very, very clearly, and I have actually justified it. The other causes are possible, although, but because of the clinical data which is available, it is very near to the acute inflammation, rather than chronic inflammation, rather than tumor, or rather than other miscellaneous condition which can cause obesity. So this is the conclusion, and then inference is this, that either I will deal this case for further investigation or not. Yes, I can deal with this case, otherwise you will refer to the pulmonologist. There is no need of it. You are internal medicine person, you can deal it. First of all, you will deal with all the risk factors should be calculated here, and go for the PORT, P-O-R-T, scoring system which is recognized by the WHO. This PORT means there are a lot of parameters, age, sex, and comorbidities, and other biochemical markers. Add these markers. If it is more than 100, 110, it is the patient is at the moderate risk. It is more than 120, it is higher risk. More is the age, more are the complications. More is the age, more are the complications. More are the comorbidities, more are the complications. This is a simple rule. And then I will go to further investigation is concerned. The lateral view, HRCT can be done, the sputum can be done because he had got hemoptysis. Exclude AFB also in this condition. Culture should be done of the sputum. And the other routine investigation other than that, because it will affect also the other system because of the septicemia, the LFTs and UCE, I will check it. Definitely I am going to check it. Electrocardiogram because it is because all the features are not seen here. will be done. And then afterwards, I will plan management, general measures, specific measures, symptomatic measures, preventive measures, surgical measures, palliative measures or local measures. Specific measures, I give the antibiotics. The most common cause is the consolidation in this country is the community acquired pneumonia, CAP. The drug we use here is mostly the amoxicillin plus clavinic acid, that is called augmentin in this country. We'll give the full dose 1.2 gram intravenously 5 days and then switch on the oral therapy. Either you use this or you use the cephalosporins of the higher generation, or you can use the carbapenems, azithromycins, etc. Meropenem is available here, azithromycin is available here. Nowadays, the WHO and American Society of Pulmonologists, they are promoting the macrolides of the third generations because it will cover most of the bacteria, azithromycin. It should be given intravenously and then go for the oral therapy for 7 to 10 days. Patient should be monitored. If in the high risk, you will admit. As a low risk patient, no problem. You can admit, you will not admit, and you will monitor at the home. This is the message which I have given to you, very briefly. Otherwise, I can talk on this X-ray and the clinical scenario for more than 2 hours. But this is the most summarized way of talking. I hope you have enjoyed with this presentation. I hope so. And learn from it some points. Try to remember it. Inshallah, we will meet it again with the case number 6 very soon. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Assalamu alaikum wa rahmatullahi wa barakatuh.